I feel like so much conversation or talk around access and accommodations has traditionally been like, what is the illness? What is the disease? What do they have? And it's very pathologizing, which is classic healthcare. Whereas I think looking forward, it's so much nicer to say, okay, what tools do we have? What would help you get the most out of these clinical or classroom experiences? Because then it's like, okay, let's talk about the tools. Let's talk about facilitating this. And it's much more on that learning process and less on like impairments or other issues that are requiring the access needs. What's involved in the work that you do educating your peers and, you know, your educators about accommodations?
I think there's kind of several components there for me. I think, of course, within MSDCI, part of it is just like sharing what we've used before, right? We've had folks who've shared their experiences. We have a group chat where people share their experiences, or people who are trying to figure out how to get accommodated for a certain thing, ask for what others have done in the past. And I think that's just, it's a really nice kind of open forum, because sometimes the most creative responses come forward and there are things that like nobody would necessarily initially think of, but that made it work. We of course have the accommodations guide, which kind of goes through the steps of applying for accommodations, the timelines, kind of financial background around what that may require. For example, like under clinical accommodations, we give suggestions of different accommodations that students may use. So just to give ideas for people to kind of get started, because the transition from preclinical to clinical can be difficult for students who haven't been in the clinical space in that capacity before. Even just kind of making the activation energy a little bit shorter. You know, one of the things that I really wanted included, and we have included in that guide, is sample emails of how to reach out to your professors or your instructors about needing accommodations. Sometimes it's just like that little bit of extra mental energy of like, okay, how do I talk about this? And students are like, okay, how much do I actually really need to say or not say? And sometimes just having that template can be really, really helpful, kind of allowing students to just have a little bit less mental energy dedicated towards navigating their disability, to kind of open that energy back up for them to focus on the medicine that they're there to learn, because that is one of the things that disabled students face. They have to put so much energy into being accommodated that they end up starting at a much lower kind of energy threshold for the rest of their medical work that they need to be doing and want to be keeping up with and want to be doing. And one of the really cool projects that I was lucky to work on with Dr. Poulos as well as Dr. Corey Puffenberger at Stanford is actually a video module that's available for CME credit that walks clinical educators or anybody who's an educator in medicine and works with students or trainees through the thinking about accommodations and really answering relevant questions. So answering like why you shouldn't, like why you don't actually need to know more about their specific illness to be able to accommodate them. Understanding why certain behaviors, even if you think you're being helpful, may actually be a bit infantilizing or you know, maybe taking some of the agency away from individuals with disabilities, right? I think a common example that's used is like pushing somebody's wheelchair for them when they're rolling it themselves and they don't actually need you to and didn't ask you to, right? I think the hardest part of accommodations is really there is no comprehensive resource, and that's actually something that we're building, you know, a more comprehensive resource around clinical accommodations. And actually Lisa Meeks and her lab, the Docs with Disabilities Initiative, is actually coming out with something that's a resource on clinical accommodations that I imagine will provide a lot more comprehensive information around the different types of accommodations possible.
That's fantastic. I was going to say, like, I have their book, Equal Access for Students with Disabilities, and it has, like, you know, there's lots of good stuff in here, but there is a section on sort of classroom and clinical accommodations. But I love that they're building up sort of a focused guide. That sounds fantastic. You did a study on just sort of a like Ableism 101 type seminar too, with sort of like a pre and post session survey. And, you know, I went through all that content. I mean, it's really nice when there's, you know, when you're meeting sort of a group of people who are new to these concepts, right? You have to kind of meet them with some grace, meet them with some understanding, because, you know, I always assume people, if they're acting ignorant or if they aren't knowledgeable, it's not because they're trying to be biased. It's just because of the culture that we've all been educated within that's flawed. So I'm just so proud that you're doing this very important work. Nora, was there anything you wanted to comment on in terms of accommodations?
So one thing in our accommodations guide is knowing your rights. That's a consistent theme throughout. Know when to get a lawyer. There may come a time when you do need legal help, and that's okay. Sometimes that's just what it takes. So if that's something that, if that thought crosses your mind, if you're getting to that stage where you're starting to have career concerns, please seek professional legal advice. It is not worth your career to not do that.
Yeah, and that speaks to sort of that energy, or the spoons, if you will, of, you know, I'm supposed to be putting all this into my education, but I'm having to fight these logistical and potentially legal battles when my education education isn't being prioritized.
It's a huge thing with step exams. That's another thing. Apply before you think you need to, because it can be something that can delay your medical education trajectory. So again, I recommend with that, please put your application in 5 months before you think you need them. Work on it, start working on it 6 or 7 months before you think you need your accommodations. Those are slightly maybe exaggerated timelines, but sometimes getting letters from doctors can take a while. You have to write a personal essay. You have to gather medical records. If you've moved around a lot, like a lot of us have, that can take a while. You may have to request standardized testing from high school. Like the reports of standardized testing from high school, which if you've been out of high school as long as we have, may take a phone call to the SAT or the ACT. It is a long process.
The earlier the better.
The earlier the better, the more complete the better. The last thing you want is to wait 3 months only for them to say, we really wanted this form.
I wanted to kind of go through a generalized list of accommodation types, just one from my understanding, and to kind of bounce them off of you, and to anyone who might be watching who is a current student or trainee or is an educator who's trying to learn more about this, just to help give everyone a better sense of like what is possible and what is usual in terms of accommodations in a learning environment. Can I run them by you and see what you think?
Sure, but I'll tell you that there's nothing usual. There's nothing standard.
That's true. Everyone is different. It takes a lot of creativity sometimes to figure out what can help facilitate someone's learning. So one big one is like an adjusted schedule. So, either extended testing time or specific work hour limits. If there's unpredictable symptom flares, flexible time off, and even sort of remote versus in-person work if that balance needs to be skewed. Does that sound like a general type of accommodation?
Some of those are easier than others. Modified schedules in the sense of you work 2 days, you don't work the other 2 days, something like that can be a little tricky school by school because they can run up against something called like a fundamental alteration. So a reasonable accommodation, it cannot significantly deviate from the intended meaning of what you're doing. What that idea of reasonable accommodation is and what that idea of fundamental alteration is vary institution to institution and disability service provider by disability service provider, and also by what your school's technical standards are.
I would agree that those are maybe more standard. Be having permission to not be at certain sessions that may have been mandatory and be able to make it up. I have seen people who have had work hour modifications. I've seen people who have schedule accommodations. I myself, the medicine rotation is 2 months long at my institution. And for me, I got to split up those 2 months where I didn't have them back to back because I was having foot surgery and, mobility wise, it would have been difficult for me. And so that was an accommodation that was made for me because I'd had a foot injury and needed surgery. It depends on the institution, kind of what they're able to work with. It also may mean that your medical education takes longer than 4 years. And so you kind of have to decide whether or not you are okay with that. Sometimes it also depends on, what you want to go into, right? Because if you're somebody who wants to go into a specialty that you don't get exposure to during your core rotations, you also may need a little bit more time to be able to do that elective, right? And do what you need to do to be competitive and to be applying into that specialty. And so that can also kind of affect your timeline, and there's nothing wrong. And there's honestly a lot of great to be found in taking extra time. I think those are all kind of reasonable examples of accommodations that could be implemented depending on the case and institution, of course.
And it sounds like from what you're saying, even the kind of more rare ones or the ones that might, that can be argued for or against things like technical standards and reasonable, it sounds like there's still precedence for a lot of them. So, hopefully that can be something we move towards as having that be more available and more accepted. The next major type of accommodation I wanted to run by you guys are things like assistive technology, which is a huge category. Things like assistive software, scribes, like an auditory amplification system, closed captioning, or there's CART, communication access real-time translation, ASL interpretation, screen readers. What are your general experiences or thoughts about these types of accommodations?
I think oftentimes these may be accommodations that require financial resources. Sometimes there's a little bit of a higher threshold of demonstrating the need for that resource. Sometimes it may be that they're offering a kind of imperfect solution or an alternative that doesn't really work for you. And it can be difficult to communicate that, I imagine, for a lot of people. And sometimes it just requires, I think, a lot of student effort, figuring out what assistive devices there are that students can use. That's also part of the equation is, right? If institutions have not used those assistive devices before, and there really isn't much standardized education amongst medical administrators, medical educators around what exists in that space. And then again, of course, even if it is possible, what is the cost to you? What is the cost to the institution? Is that feasible for both parties? Sometimes for the institution, to them, it becomes an unreasonable accommodation if it's particularly costly, especially if it's costly on a continuous basis. And for medical students, a large number of whom are dependent and living off of loans and, are trying to maintain some level of a budget, like taking on expenses that can be additional thousands of dollars, can sometimes be quite limiting. And I think that tends to be the barrier. And then also who's responsible for acquiring that technology.
Very good point. Very good point. And it's so frustrating that is the reality because, when we talk about academic institutions that receive federal funding to a certain extent, they are required to be compliant with the ADA and, an assistive technology device like to facilitate someone's learning. At the surface, that seems like a reasonable accommodation and, part of the educational experience that the school is supposed to be providing. So I can see both sides, and it's frustrating that institutions haven't made the shift to just budget for those kinds of things. I think that is possible and that needs to happen more.
There are outside organizations that may be good resources. So there's the Association of Medical Professionals with Hearing Losses. They may have resources or recommendations if you're like, I need some modification due to my hearing loss or my auditory processing. How do I do that? They may be a good resource. Also, every state has assistive and adaptive tech lending libraries, and some of those have grant programs. So they may be good resources for certain things. They may not have everything. I highly doubt they're going to have things like amplified stethoscopes, but they may have grant programs that can help you get where you need to be in order to financially justify that cost.
You're just opening me up to this whole world of resources that, even if you don't know the answers, you can point someone in the right direction. Go ahead.
We also have a living document of resources that's different from our accommodations guide that includes a different relevant professional societies and different like self-advocacy things. And we can give you that as well.
I think the last big category of accommodation requests that I wanted to run by you guys are things like environmental requests. So considerations of like lighting, noise, allergens, maybe even just having personal items in the environment like food, water, medication, assistive devices. What's your experience with kind of how those requests are received?
Well, what I was going to say is if you want snacks in a test or snacks on you or the ability to go have a snack because maybe you're diabetic and you need to regulate your blood sugar or something like that, that's usually pretty easy accommodation for most things. If it becomes an issue of DME and you're in an OR, that may be a slightly different issue. If it's wanting to have a scent-free environment, maybe that's something that can be a thing in your small group, but you can't make that request of patients. Trying to control the environment around you does become kind of complex, but trying to control what you can bring in and out of the environment is usually a little bit more manageable. It does get, again, a little bit more tricky when you get into things like ORs with sterile fields and having to scrub in and out, all that fun stuff.
External factors within the environment can sometimes be difficult to control. And there are certain things where it may not be, if bright lights are an issue, but you're in the OR and, the surgeon needs the light to see the field, that may be something where it's harder to kind of navigate, what's doable. And so there has to be some level of kind of consideration for the other factors. But I think, like Nora said, the things where it comes to environment and bringing in resources for yourself, I think I don't think I've encountered anybody who has needed, food as a diabetic that hasn't been allowed to have food on them or go and manage their blood sugar, maybe in part because diabetes is such a well understood condition that it would be hard to find a physician or a healthcare provider who said, no, it's okay, your blood sugar will survive, because no, they know that it's a necessity. You are already bringing in what you need, right? The food, the water, the medication, medical equipment, the assistive technology, that usually becomes a little bit easier to facilitate versus when the change is required of the external environment, especially when it's an external environment that's communally shared and your use of that space may not even necessarily be consistent, like on clinical rotations where you may be in different clinic rooms, in different ORs, you know, in different workspaces.
One thing we haven't touched on that is important to touch on is the difference between formal and informal accommodations. Most of what we're talking about is formal accommodation, where you go through your school, you go through your disability service provider, you provide documentation, which is actually like not required by the ADA, but is a requirement usually for schools because they want to make sure you have the documentation for when you go to do things like apply for STEP accommodations. There are also informal accommodations, which tend not to be recommended because if somebody denies an informal accommodation, there's no good recourse. However, if there's something where you may not be able to get it formally accommodated, but you can, under very specific circumstances, make a request to an individual person, that may be a thing you can do. For instance, I'm going to go back to the environment, smells, right? So like maybe there's a specific perfume that gives you migraines. There's a specific scent. You may be able to say like, I'm so sorry, like I can't, this is going to give me a migraine. Is there any way I could go see this other patient instead? Would that be okay? They may say no. You can ask. That may be the way to get around some of that in a way that if it can't be formally done under certain circumstances, it may be informally done.
I think one thing that's always just kind of good advice and good kind of habit is to make sure that whatever you're doing is documented, right? So that doesn't necessarily have to be a formal email saying, Dear Dr. X, like I wanted to send you an email so that I could formally document that you provided this. It could just be, Dear Dr. X, thanks so much. Had a great day in clinic. I really appreciate you, accommodating my need for XYZ. It's a thank you email. It's polite, it's professional, but it also gives a baseline where there is some documentation to refer back to. And that can be helpful both in that rotation if anything comes up, if there's a concern, but also in future rotations where you're like, oh, okay, like I know this person did this with me, like this was, our plan. I can forward it to, and you forward it to your clerkship advisor or your disability service provider, say like, this is what we did here. It seemed like it was reasonable in this space, like hopefully would be reasonable in another space that's similar, right?
And also if somebody says something nasty to you about your disability or accommodations, write that down too. Tell somebody that you trust that's in a position of power because these people are grading you. And if something comes back in one of your evals that you feel like is a little ableist or blatantly quite ableist, having that written documentation of, I had this conversation with them about my accommodation and they made this snide comment. Recording early and often can kind of head things off at the pass a bit.
Yeah, and you're speaking to, same thing with other isms like racism. There's macro ableism that's quite blatant and on a systemic level. And then there's like microaggressions, micro ableism, not necessarily intended to be negative, but can be tokenizing, objectifying,
right,
infantilizing. So I agree. It's so important to encourage that accountability and that feedback. This has been such a fantastic discussion. I really appreciate all of your insights that you've shared on, just accommodations in general and a lot of personal perspectives too. Is there any other sort of advice or thoughts you have for maybe fellow medical students or faculty and educators who are kind of newer to these concepts?
I have some recommended reading. I highly recommend Dr. Diana Sejas' essay in Disability Visibility. It's part of what convinced me that I could be a disabled person in medicine. I really recommend Emily Ladau's Demystifying Disability. It's a great primer for learning more about disability as an idea and touching on a little etiquette, touching on a little history, where it doesn't oversimplify, but it's not so technical as to be alienating.
Right, it's accessible.
It's accessible.
I admittedly started this only in 2018. It's not like I've been, an active learner within the disability space for all that long. I'm still learning and still growing as somebody who's gaining a deeper and deeper understanding of disability studies and rights and so on and so forth. So I think it's really just about the way you come into these things. And I think this relates not just to disability. I think it relates to, all of the areas in which there's bias in medicine. Be willing to do the work, be willing to listen and to be open-minded, to recognize when you may have misstepped, acknowledge the harm that that may have caused, there are a lot of resources out there, and it's okay to not necessarily know of all the resources out there, but do take on the onus of finding resources rather than expecting or relying on individuals with disabilities to be your educators. And this is a really common theme that particularly around racial bias, where it's kind of just an additional tax of having to explain to those who don't get it why, like, what you're trying to say and what you want them to know. And I think it's the same thing for individuals with disabilities, right? It goes back to not necessarily needing to be known as, oh, the disabled girl or the disabled guy or whatever, right? Like, you have more to you. And I think when people are coming into the space, it's often easy to turn to the person who knows about this, often through lived experience. For the community, it often can be really helpful to see individuals who are not part of the community making their own active efforts, is I think what I'm trying to say.
Yeah, allyship. 100%.
Come to this YouTube channel, right? Like, that's the thing. There are thankfully growing numbers of resources around. So I think it's really just about like turning to the resources that exist, and kind of doing your due diligence in getting that primer yourself.
I love that. And I feel like that's the most welcoming sentiment, forgiving people who, may have not been knowledgeable before or may have said harmful things in the past, still welcoming them onto the lifelong learning train. We chose medicine, we're in this for life, and encouraging that same attitude amongst others. I feel like that's what healthcare should be all about. And that's what advocacy is all about. So thank you for sharing that. And thank you for plugging the channel. Thank you so much for tuning into this awesome conversation with the MSDCI leadership. If you want to learn more about accommodations and creating equitable, accessible learning environments, hit that like button and subscribe to This Ability Clinic for more accessible, inclusive, and entertaining education. Thank you so much for watching, listening, and learning. See you next time.
That was cool. I love that you incorporate ASL. That's so cool.
Yeah, I'm learning design. There's a great app called Lingvano, if you guys are interested.
Will you text us that?
Yes. It's not the cheapest thing, but I feel like ASL is such a great tool. And for me, it's easier to learn than, I'm also trying to learn Vietnamese via Duolingo. And that is very, very challenging. So ASL is kind of like, oh, this is the easier one.